I'm going to speak about gluteal tendinopathy today. As an outline, we're going to look at the definition, do a discussion about the definition of the tendinopathies, look a bit about histology, histopathology, and the pathophysiology of the problem. Very quick look at the classification of tendinopathies in general, and we'll touch on great trochanteric pain syndrome, the anatomy of the area, the epidemiology, differential diagnosis, and look at the symptoms, examination, diagnosis, and treatment. It's very important, I think, to know a bit about the definitions that they are used. Not only the term trochanteric bursitis is being used generally, but there are some differences, and looking at the pathophysiology of it, it's good to know these. So tendons, we know they connect the muscles to bone and they allow transfer of the forces. The term tendinitis is the description of a tendon impairment that's associated with some introtendinous inflammation. And tendinosis is another term that is used to describe the degenerative tendon changes without having any inflammation signs or any correlation with clinical symptoms. The best term that can be used, or best descriptive term that can be used for the disease that they happen in this area will be tendinopathy. It's associated with impairment of the performance, and sometimes associated with swelling, but most of the time there will be no inflammation in the area. And as I said, this is the best generic descriptive term that can be used for this clinical condition. That the primary cause of it is the overuse of the tendon. Trochanteric bursitis is a term that's been widely used. It's first described by Stigman in 1923. It's a term that they use for chronic and intermittent pain that's accompanied with tenderness of the lateral side of the hip. It's been called as a great mimicker because there are a lot of problems that they present with that pain with the area, and it's not caused because of a problem in the gluteal tendon. This term may not be the right term to be used because the only time that inflammation is seen in all those tendinopathies or problems of the gluteal tendon is at the beginning of the process, and after that there isn't much inflammation present. So it's better, preferably use the term tendinopathy rather than using trochanteric bursitis. Very quick look at the structure of tendon, the fibrils and the collagen fibers, and then fascicles, and the fiber bundles, and then the tendon. It's covered by the epitendon, that's all of the blood vessels, the nerves and the lymphatics go to the tendon and goes between those fibrils and forms the endotendon. And at the outside of the every tendon, you've got the parotendon as well. That's also a thick layer presented on the outside of every tendon. In terms of histology and histopathology, normally the 95% there are tendinoblasts and tenocytes. Tendinoblasts are the immature cells that they form the tenocytes, that's the biggest cells that's there. And the rest of it is normally chondrocyte, synovial cells of the tendon sheet, also the vascular cells. Looking at it macroscopically, a normal tendon is normally glittering white and has a firm fibroelastic texture. Comparing it to a tendinopathy, the color of its change will be grey or yellow-brown, and it's soft and friable and fragile, and may have some edema in it. Microscopically, in tendinopathies, normally the collagen is disrupted, and the fibers are thinner than normal, and there's loss of the classical hierarchical structure that's present in a normal tendon. Also, the cells that are there at the side of the tendinopathy, they normally produce abnormal collagen. That's maybe the reason of this soft formation of the tendon in the microscope. Looking at pathophysiology of these tendinopathies or gluteal tendinopathy, there are different factors that are present there. We have intrinsic factors and extrinsic factors. There are some structural factors like the morphology or the metabolic reasons, also the extrinsic factors like excessive load or repetitive trauma or contusion, that this causes rupture of the fibrils and damage to cells. And the next step is patients will get a reactive tendinopathy, that's an inflammation in the tendon. Either this excessive loading keeps going and keeps continuing, or then it's been reduced. If you give the tendon enough time, there will be some time for it to regenerate and adapt to the situation and have some anatomical healing happening, and then that will lead to clinical healing after the strengthening. If this loading keeps going and continuing, this will cause tendon disrepair. The tendon will not repair itself properly, and then that will cause degenerative tendinopathy. That with some treatment modalities, we can get to clinical healing, but if this stress keeps continuing, this will cause the rupture of a tendon. About the tendinopathy, they try to describe different classifications, different stages in terms of the symptoms that they have and function have been described. This was the first one that's been described, the 4 stages. They had pain after sporting activities. Stage 2 is when the pains present at the beginning of the activity, but it disappears after warming up. And some people have pain at rest and during activity. At the last step, these patients will have rupture of a tendon. Also, chronologically, it can be classified into acute, subacute, and chronic. Between 0 to 6 weeks is acute, and subacute is up to 3 months, and chronic is after 3 months. Also, niche is just another pathological staging, 4 stages, as well as another different phases for the pain. Some pain that they go away in 24 hours, there's pain that goes away after 48 hours. Stage 3 is pain that is presented with exercise activity but doesn't alter the activity, then it will alter the activity, and at the end is pain at the last stage that presents at rest and it can disturb sleep. The term that's been generally used nowadays instead of trochanteric bursitis is greater trochanteric pain syndrome. The primary pathology behind trochanteric bursitis is that tendinopathy or tendinosis that's present at the gluteus medius or minimus tendons, and as I said, there isn't much inflammation, so using the term trochanteric bursitis may not be the best. This is why the greater trochanteric pain syndrome is more accurate to describe it. And also, this pain on the side of the hip is caused by different pathologies. That one of them can be the gluteal tendinopathy or problem with the gluteal tendon. Looking at the anatomy, the main 2 muscles here, the gluteus medius and maximus, that the origin of it is the ASIS and the outer edge of the iliac crest. It's got 3 distinct portions. The gluteus medius muscle is got an anterior, middle, and posterior portion. 2 distinct attachments are there. The supraposterior facet, that's the posterior bone orbit will attach there, and also we've got the lateral facet, that the anterior middle part will attach to the lateral facet. As you know, innervation is supragluteal nerve, and the function at the bundles, they work differently. The anterior middle part, they're normally vertical, and they help with hip abduction. The posterior one is horizontal in line with the femoral neck, and its job is to stabilize the hip joint in the gait from heel strike to full stance. The gluteus minimus origin is a anterior inferior iliac spine to the posterior inferior iliac spine, along the medial gluteal line at the back of the ilium. And it's got 2 insertions that have been mentioned for it. One of them is the capsular head, that's an anterior part of the GT, and the long head that sits the lateral facet below the gluteus medius tendon. The nerve is the same. The fibers are in parallel to femoral neck, and its job is also to stabilize the hip joint during the mid and late stages of the gait cycle. The picture demonstrates the muscles that we can see on the lateral side of the hip, including the gluteus medius and gluteus minimus. And this is also the areas that all the tendons attached to the GT on the femur. There is an area that's called the bald spot. This is where there is no muscle attachment available in the area. There are different bursa available in the area as well. The trochanteric bursa, the one that normally discussed, is just underneath the iliotibial band, superficial to the gluteus medius. Every one of those muscles, gluteus medius and minimus, they've also got a bursa that's deep to their tendon. Both medius and minimus, they have this, as you can see in the picture, they've got those bursas. In terms of epidemiology of gluteal tendinopathy, the incidence is 1.8 in 1,000 people per year. Prevalence is between 17 to 35%. Looking at the gender, it's more common in female compared to male. The ratio is 4 to 1. the reason may be because they have a wider pelvis, and maybe the femoral anteversion may be another reason. It's more common in female. Incidence is increasing athletes. The main reason is that they need to do more training, and excessive use of the muscle may be one of the most important reasons that it's becoming more common in athletes. Looking at the age, the peak incidence is normally within the 4th and the 6th decade of life. So the main reason for consultation in the States for musculoskeletal complaints, and about it accounts for about 30% of consultations with a general practitioner in the States. Different conditions can cause this greater trochanteric pain syndrome. One of them is hip osteoarthritis. Normally people that they have pain, they will have limited range of motion that can help to differentiate. Sometimes fracture of the proximal femur can be another cause of pain. Normally these people cannot perform their straight leg raise when they've been lying supine. Neuropathy or iatrogenic injury of the supragluteal nerve is another cause of getting the pain around the greater trochanter. It's a rare condition, but may be associated with other medical problems like diabetes or rheumatoid arthritis. Problems in the lumbar spine is another cause of getting this sort of pain. Low lumbar spondylosis or lumbar spinal stenosis is other spinal cause of this sort of pain. The pattern of the pain is different than it's a radicular pain rather than being localized. Sometimes the Gluteal Tendinopathy, they have a pseudo-radicular pain, comes to the side of the thigh but doesn't go below the knee. And the patients with the lumbar spinal stenosis, they will have a limp and they present with some hip abductor weakness. Different conditions have been mentioned other than the one that we described as other causes of greater trochanteric pain. Obesity is one of them that's good to mention. Iliotibial band syndrome or snapping hip is another cause of getting this sort of pain. In terms of symptoms, the patients normally present with a chronic and persistent pain in the lateral side of the hip or the buttock. Normally the onset of it is insidious, but in some cases they may present with an acute pain. The pain may radiate to the buttocks, groin, or the lower back, but as I said, doesn't go below the knee. It normally gets worse if the patients lie on the affected side, if they stand for a long period of time, if they changing from sitting position to standing position, or if they sit with the affected leg crossed. When they go upstairs or they run or they do high impact activities, these things also aggravate the pain and the symptoms. They also may complain of reduced strength, and they may also say that their leg feels weak. In terms of the physical examination, they normally have tenderness over the lateral aspect of the greater trochanter. In physical examination, the range of motion of the hip, most of the cases may be normal. They will have a trend-lombic sign. They will have pain with resisted abduction and internal rotation, and the Albert test and also the Faber test will be positive in these patients. Look at the Albert test. This is normally a test that's been used to diagnose the iliotibial band syndrome or checking the contracture of the iliotibial band. The patient is normally lying down on the lateral position. Then the affected leg is abducted and the hip is extended, and then the leg is allowed to go to abduction to neutral, and when it passes neutral alignment, this will cause pain. And the positive test is shown by inability to abduct past the midline. This is a picture of showing how the test is getting done. To do the Faber test, normally the patient has to be supine on the bed, and the affected leg has to be flexed, abducted, and externally rotated, and the ankle is rested on the thigh of the affected side. Then the examiner puts one hand on the anterior superior iliac spine on the unaffected side, and then applies some downward pressure on the affected leg. And this test will be positive if the patient will have pain in the affected hip. This also can be a sign of problems in the sacroiliac joint, and people that they have sacroiliac pathology will also have a positive test. Picture of how doing the test. They tried to describe some diagnostic criteria. One of them also was the Pratt-Anderson diagnostic criteria, that they, in order to diagnose trochanteric bursitis, they said there should be lateral hip pain and tenderness over the greater trochanter, following with one of the other criteria. One of them is pain at the extremes of rotation or abduction, pain when there is forceful contraction of the hip abductors. Also, pseudo-radiculopathy, the pain goes down the lateral side of the thigh. These have been used in practice, but none of them are sensitive or specific, and the predictive value has not been established in literature. These are also other diagnostic criteria that they've been used in literature to diagnose the trochanteric bursitis or gluteal tendinopathy. In terms of diagnosing this situation, diagnosis is typically most likely clinical. Other tests will help diagnose other pathologies that they may be in the area. For example, X-rays can be useful to diagnose osteoarthritis in the hip joint. Normally, the plain radiograph are unremarkable. Sometimes some sclerosis of irregular borders can be seen, or some osteophytes on the superior part or inferior part of the greater trochanter can be seen, also on the anterior edge of the greater trochanter. Bone scan is a test that may show some increased uptake of the greater trochanter, but it's not specific to this condition. Ultrasound may also show some change in the signal. MRI is a test that's been used widely. It can show a high intensity signal in the greater trochanteric area, but this change of signal is not always clinically significant. The T2-weighted images are the best images to have a look at and diagnose the problem. If there's a partial thickness tear, this will appear as a thickened appearance of the tendon. If there is a partial tear, there is focal discontinuity in it, and the complete tear is normally diagnosed by the retraction of the torn tendon. Different treatment modalities have been described for this condition. There are non-operative and operative treatment methods used. The most common one is to modify activity, avoid lying down on the affected side of the bursitis or gluteal tendinopathy. Anti-inflammatories have got a role in treatment of them. Eccentric exercises will help with treating the problem. Most of the patients, normally the pain symptoms will resolve with those first three modalities. Some talks about some shockwave therapy that may be helpful in these tendinopathies. There's some discussion about what sort of shockwave should be continuous or it should be high intensity or not. The use of steroids and anesthetics can be helpful in the area. There's some papers that looked at the effect of it, and most of them are showing that they will help initially with the pain. And some of them have looked at doing it under fluoroscopy or without fluoroscopy. There are some talks about the use of platelet-rich plasma and autologous blood injection. The role of it is not clear at all. It's been suggested it will be helpful in other tendinopathies in other areas of the body. The way it works is that it causes inflammation in the tendon first, and then that will cause proliferation and then remodeling of the tendon. This is by causing that inflammatory phase that helps healing the tendon. These are the four different papers that they looked at the effect of the injection of steroids, and the first two have shown that most of the patients have got very good effect and good relief with the injection of steroids. The third one has looked at the use of fluoroscopy and see if the injection is going to work better if it's been done by the use of fluoroscopy. And they showed that fluoroscopy is needed to make sure that the injection goes into the bursa, and this will help with the pathology. But the next paper that's been published in BMJ in 2009 actually shows that the use of fluoroscopy will not improve the outcome. So if you use fluoroscopy or not, that may not matter. In terms of the operative management of this problem, normally it's used for calcitrant trochanteric bursitis that does not respond to non-operative measures. Generally, the main role of it is normally remove the thickened bursa, remove any spares that they may have formed around the area of the greater trochanter, also try to relax the large tendon of the gluteus maximus. Different methods of different operations have been described. One of them is normally to try to do some simple longitudinal release of the iliotibial band and also excising the bursa. It can be done open, also arthroscopically. The other ways of fixing the problem is either to do a tendon repair or do a tendon reconstruction of the area. In terms of repairing them, it's been divided into three main groups of tendon tears that will respond to repair. The first group is when there is a degenerative or traumatic tear of the abductor tendons, or the other name of it is the rotator cuff tears of the hip. That in these cases, then normally the tendons are repaired using very heavy sutures with transosseous sutures. In the cases, the ones that they've been described in a study done by Kagan and al, they left the fascia lata open after the repair was done to prevent impingement of the fascia over the suture line. I'm not sure how helpful that will be. In the other studies, they haven't either mentioned or they've closed the fascia. Davis as well, they had 24 patients. They repaired with transosseous sutures and anchors. All except the one, 23 of the patients improved. The pain has improved and the strength returned back to normal in 2 years follow-up. There was also another study, that's an Australian study that's been done in New South Wales, in St George Hospital, that they had 89 patients that they were treated between 2000 and 2008. And they used transosseous sutures using 5-etibond, and they've closed the fascia in those ones. And at 6 months follow-up, they had 88% of the patients had minimal or no pain. One of the things I think that was a bit different compared to the other one is that they kept their patients non-weight bearing for 6 weeks. So if that's affected their success or the result. The second group of the tendon tears that they get repaired are the ones that they are found at the time of doing hemiarthroplasty for an off, or doing an elective toe hip arthroplasty to manage osteoarthritis. In the group of patients that they're normally asymptomatic, they have no pain in the area, and then that is seen intraoperatively. The incidence of it in different papers have been described to be between 20 and 22%, and normally it's seen in more older people than younger patients. Same repair is used for this group of patients through transosseous sutures through the greater trochanter, and the results are pretty good in this group. Again, the third group that can be seen is people that they have an avulsion of the tendon after they had total hip arthroplasty. That's normally through the anterolateral or transgluteal approach or the Hardinge approach. As we know, one of the main problems with this approach is the insufficiency of the muscles and limping that can happen. Normally, what they do after the patients have the total hip arthroplasty, they come back with the limping and the weakness of the muscles. The approach is to go and try to refresh their bony bed and get rid of the sclerotic bone that's present there, and then use heavy sutures to reattach the tendon to the greater trochanter via transosseous sutures. There was an osteotomy as also mentioned, but that was the way that they used this as a salvage procedure after the original operation of bursectomy or the release of the iliotibial band did not work. They did an osteotomy medial to the insertion of the gluteus medius muscle, and they extended distally and laterally to the vastus ridge. Then they took about 5 to 10 millimeters ridge of the bone, and then they've transferred the trochanter medially and distally, and they've secured the cortical lag screw. In terms of reconstruction of the tendon, there are two methods that they've been described. One of them is a flap from the gluteus maximus, that's the posterior flap that's is being brought forward, And it's used in people that had osteolytic destruction of the GT and had abductor insertion insufficiency. Also, the other one was to use an Achilles tendon allograft to replace this abductor tear that was in the area after the total hip arthroplasty. But they used it in 7 patients. There's also a role of using biological and synthetic scaffold. The scaffolding will help the healing process. If it's biological, it's good because it can integrate with the tendon or with other soft tissues around the area. But there aren't too many biological scaffolds that can be used in the area. So the other thing is to use of the synthetic scaffolds. It's going to be good. It's a strong graft, but the issues with them is they're not absorbable, and they're not biocompatible, and there's high risk of infection if you use them in these areas. There was a study that's been published in Hip International in 2011 that there's a prospective cohort, and they did gluteal tendon reconstruction in patients that had hip arthroplasty. They had 10 years follow-up, and they had 24 patients, and they used a large graft for it with suture anchors and the suture down to the bone. And from there on to the 24 patients that they had 2 failure of their fixation, and one of the patients died of unrelated causes. The other study that used this synthetic scaffolding was a study that used called the graft jacket, done by Wright Medical, and they had 12 patients that they used the transversus supra of the gluteus medius and minimus insertion, and their patients, their symptoms have improved, pain, limp and gait improved, and their strength returned back to normal. And they mentioned that trend element test became negative in 11 of 12 patients. And they've suggested that this procedure is a safe procedure and associated with high patient satisfaction and without morbidity of any tendon or the muscle.